So, David, why don't we try to start with just kind of setting the table just so everyone knows where we are in terms of confirmation. Um, Secretary Kennedy was confirmed a few weeks ago. He is, if you will, off and running. Anything you want to add in terms of the HHS secretary and sort of where he has started to focus?
Well, he's beginning to pick his people for the office of the secretary. Some of whom have you know been in the administration before with Trump, and some of them are newer. But they are beginning to do the work that they've kind of been promised to do. They've been every one of the department heads has been charged by Trump of being responsible for any reorganization, any efficiency efforts, any cut down on anything that would be considered basically, like, let's see, redundancies. I think redundancies are some of the things that we see being talked about a lot. And so he has begun to work on that in a very large way. He has announced a reorganization that, taken along with the Doge cuts, is a reduction of about 20,000 people at HHS. HHS was at 82,000 before this started, and now it's going to be about 62,000. It was at 62,000 last time in the early 2000s, 2001, 2002. I'm not sure exactly which one it was, but so it's been a while. He's been closing regional offices and consolidating them, different divisions and different offices. All that kind of remains to be seen as to whether exactly how that will work. Um, and there's also consolidation going on within this administration for a healthy America, that they're calling it. That's going to put together a whole bunch of groups, including HRSA, which we talk about, where a lot of the transplant activity occurs in the agency world in HHS, as opposed to CMS, which actually oversees more of the payment of transplant. But so there's a lot there happening. It's it's kind of like watching one of those um, I don't know which would you call it, but one of those action-packed movies where they all of a sudden there's a big car crash and everything blows up, but then it turns to slow motion and you're trying to figure out where everything goes and where it all lands. And that's a little bit of where we are right now, and everybody is working kind of around the clock to figure out where all the pieces are.
Yeah, you mentioned Doge. I mean, one of the things I just completely missed, and in hindsight, I'm embarrassed I didn't catch this or didn't predict this more accurately, is it's almost like they came in the first couple of days or first couple of weeks, were very aggressive in terms of cuts, many of which have been reversed or have been declared to be um, illegal or again, unconstitutional. Now they have people in place like RFK Jr. as HHS secretary, and they're taking a slightly more deliberative approach in terms of saying, come back to us with your recommended cuts. Here's the number you have to hit. And in some agencies, you can sort of see the alignment. So a good example would be with the Internal Revenue Service. I mean, if you are against the collection of taxes, it's relatively easy to say that eliminating people responsible for that role aligns with your priorities. I think it's tougher in an agency like HHS. Yes, there are some cuts around, say, implementation of the Affordable Care Act or the administration's opposition to issues around workforce diversity, equity, and inclusion. But in other areas, they recently announced an initiative focused on autism. I don't know how you do that if you're also cutting people with expertise in that arena. So it seems like there's a lot of, if you will, conflicting things happening, and that aligns well with your analogy in terms of the slow-mo of trying to see the pieces of a car crash as it's happening.
Yeah, the interesting thing is, as we watch this, those of us who've been doing this for a long time, um, it is apparent that while they want to make major change, there does not seem to be the idea that the government should stop its functions. They actually do see the purpose of the functions. For example, the consolidation of divisions and regional offices could be difficult for some people, but they are not suggesting that you completely get get rid of those those spots, in particular those activities. But I don't want anyone to be confused by what I'm saying and to think that ASN is sitting here going, "Oh, it's all fine. Don't worry about that." No, we are watching this very closely, and we are trying to meet with those individuals as they come into place, and figure out exactly what will happen. Like I said, with the various groups that are being be consolidated together. CMS, Centers for Medicare and Medicaid Services, which are play a very big role in the delivery of kidney care. Um, they were one of the smallest of all of the agencies within HHS. Their cuts, they got approximately 300 people cut, which sounds like a lot, but FDA was 3,500 and CDC was 2,400. So, that's a very big difference. So that seems to be happening. Dr. Oz, well known to everybody, is in place as the new administrator for CMS. Abe Sutton is in place of the Center for Medicare and Medicaid Innovation, which is where the models take place. And our understanding is that the model that we've been working on for so long, the IOTA model on transplant, is being set to go into effect this summer as was planned. So there's a lot of things that are happening, and we are trying to move forward. Communication has been rocky because one of the things they did was, as they made these major changes, they shut down the communications operations within some areas in order to not have things coming out that hadn't been approved. But at the same time, they've gone into, agencies where there's like 100 or 150 different communications officers spread throughout, and they're trying to consolidate that. I'm staying agnostic as to how that works and whether it does work or not. But the point is that it is made a little difficult to kind of find out all the information you need.
So you've mentioned HHS and CMS and CMMI. I guess my next question in terms of an agency is the status of the National Institutes of Health and its next director.
Well, when we talk about the National Institutes of Health, the important thing is to recognize that the word is institutes. It is plural, and everybody knows that. So they are, different institutes. Their new head is in place, and that is Dr. Bhattacharya, but nonetheless, he is in place. And he actually has been communicating back with people in the community, including ASN, even just sort of recognize that we've reached out and, uh, and wanted to meet with them and to, have communications with them. So he is in that place. It's hard to figure out because the secretary also said within the last couple of weeks that while there were 1,200 employees that had been decreased from NIH, that they were not looking at doing a total reorganization of NIH. On the other hand, I'm hearing that there may be some more cuts there. I do not know. The thing I do know is ASN has joined with a huge contingency of healthcare groups across the United States and made a major request in the increase of funding to NIH for grants with Congress. And Congress does still support a fairly bipartisan approach to NIH. So a lot of things are going to have to be worked out in that process, but we are continuing on fighting for just robust resources to keep NIH operating and to keep the level of research this country produces at the quality that it's been.
Yeah, and I think it's fair to say that we've all been discouraged in the sense that NIH has come under probably more attention again than I think most people anticipated, and that there have been heavier cuts in very specific areas, but also some issues related to specific institutions. And then finally, the whole conversation around the indirect costs. There's also obviously not a lot of clarity about the current administration's support for the intramural program in Bethesda. So all of those are vulnerabilities. And I think when we had the ASN Hill Day in March, I was struck by meetings with both Democratic and Republican offices that there wasn't the same level of bipartisan support for NIH that there's been in the past. And kind of my sense from those conversations is the combination of the disagreements around some of the issues related to the COVID-19 pandemic, as well as the establishment of ARPA-H within sort of the NIH confines. I think that sort of that combination may have really strained the relationship with Capitol Hill, both with particularly Republican offices, but also some Democratic. And so I do think we really have our work cut out for us on sort of bringing back or maintaining or even trying to expand NIH support in the coming fiscal year.
I would not disagree with you at all, and I I didn't want to suggest that things were rosy, but I am saying I am noticing that there's still some amount of the government structure still in existence. But you're right, we have a lot of work to do, and that's just kind of that is just kind of part of what we're going to all have to do and buckle down and do. But the one thing though, I do say that when we went to the Hill for those meetings, yeah, I do know what you're talking about. I did sense that, but I did also sense that there was still a strong understanding of the importance of kidney in healthcare, and what's been built on for so long, and that needs to be maintained because it is a very important issue. I am keeping my fingers crossed, um, and I know that's not a strategy, but I still will do it, that the focus on chronic disease is critical and may also be helpful in advancing the policies that can help the kidney patients and kidney healthcare workers.
Yeah, I mean, if I were trying to make the case right now to the administration for increased research funding for kidney diseases or research in kidney diseases, the case I would make would be this has been underfunded as a major chronic disease for the last 50 years. The federal government has a amazing commitment to funding dialysis and therefore paying for people who reach kidney failure. And so that provides a disincentive in terms of addressing ways to improve care earlier so that people don't advance to kidney failure. And then during the first Trump administration, there was the executive order, and there were specific mentions of both research funding, but also efforts to improve care and to make transplant more of a viable option. And so you sort of line that all up, and I think you've got a pretty good case. And as good a case as certainly any other chronic disease. I do worry though, just sort of shifting to our next confirmation or our next agency. It seems like there's probably been more turnover at the Food and Drug Administration than just about any agency. And the good news is they do have an administrator confirmed, so hopefully that will help. But I'm just sort of curious as to your initial thoughts as to the situation at FDA.
That's really hard to um, kind of address at the moment. And so you do have Dr. Markari, who has been confirmed and is in place at FDA. And we, I think we're having probably a little bit more trouble figuring out exactly what is going on at FDA than almost any place else. They have had a large reduction in the number of full-time employees, and they are saying that they're streamlining operations. We are going to watch this as carefully as we can. We are working. We also it's just so that people listening know that we are also working with them, with the FDA staff on making sure that we kind of closely monitor the situation with the shortage of blood supply lines that impact hemodialysis patients, and are making sure that the information that needs to be out about that is available. And we're monitoring that very closely along with the chief medical officers for all of the dialysis organizations.
Yeah, it's an interesting point that on the one hand, and I'm trying to think of an analogy here. I mean, we're trying to keep several things in our heads at the same time. So we have everything that's happening with Doge, which is one challenge. We then have all of these confirmations and these new sort of initial efforts from the incoming, HHS secretary or commissioners or administrators or directors. That's the second piece. Then the third piece is thinking about both the current fiscal year, where they've extended the budget and we should have a little bit of stability, but obviously there's still a lot happening, partially because of the Doge effort. But then really focusing on fiscal year 2026, which starts October 1st of this year. So starting to really advocate for those budget numbers. And then the fourth thing we're trying to deal with, as you just said, which I think is a really important point, is crises as they pop up, like the one you mentioned. And those normally we're spending a lot of time on those. And it's been a little bit difficult getting people's attention, not so much the career folks at the different agencies, but sort of getting some of the political folks to realize that some of these things are happening. I'm just sort of curious as to what are some of the other kind of just business as usual, because it's in the daily sort of advocacy efforts that are occurring that's important for our listeners to know about.
Well, I mean, well, Todd, I'm going to start with something, a film I liked very much ago from that came out in the last couple years. I think the title scares some people, but it didn't. I actually enjoyed the film, and it was called Everything, Everywhere, All at Once. And that's the bit of our society in the moment. The information age of everything, everywhere, all at once, and you can see it. You can put it up on your devices and your everything possible. But the government itself does seem to be continuing on, and we are looking at things. For example, we just got the final rule on Medicare Advantage. Medicare Advantage is going to continue to be a very big deal. It's very interesting. There was a little breathing room given to Medicare Advantage contractors on a couple things in the final rule, but not everything. And we are seeing, once again, strong bipartisan pushback on the Hill saying, particularly from a lot of Republicans saying, we like Medicare Advantage, but we've got to rein in some of the spending, some of the prior authorization issues, and we've got to be making sure that we are not mishandling the use of the taxpayers' dollars. So I think that's going to be an ongoing piece of work, and I don't think it's going to be a smooth cakewalk for those insurers. I think they're going to have to produce some real evidence that they're hearing what's being said to them. Um, and there are other areas. Now we are going to see some consolidations, and we're not quite sure exactly what will happen, and that's going to happen in the Assistant Secretary for Planning and Evaluation and ARC. And that's where a lot of stuff around kind of emergency situations has come up in the past with us. So we are going to be watching that very closely. But in general, and they are preparing at the moment, they are preparing their rule to go to OMB, the proposed rule on the ESRD PPS QUIP, which we deal with every summer. And that is going to be, and that is also something that we across the section of ASN in lots of different areas are working very hard on trying to develop a solid proposal that we can join the rest of the kidney community in talking to Capitol Hill specifically about reimagining the bundle. The bundle is stuck in 2008 in terms of healthcare policy, and I don't think anyone's really arguing that it needs improvement. And that is something that we are doing within ASN, with ASN members and with ASN staff, and other groups in the kidney space are also doing it. We're all in communication with each other. So I do expect to see that continue on. That's probably more than 1 year project. It's probably be more towards the end of this year into the next. But we will continue to look at that and work on the various things that are meant to be, that can really be helpful to like streamline that process.
Yeah, it's probably a good place to close. I mean, so we've talked at a high level about, where things stand with the confirmations. And I think your analogy of everything, everywhere, all at once is perfect in terms of this moment in time as we enter, if you will, the second quarter of 2025 and the sort of early stages of this administration and this Congress. I do think your point about there are opportunities here and perhaps reimagining the bundle being one of the more appealing ones if we're able as a community to come together. I'm just sort of curious if there's something else you might be optimistic about.
Well, I'm optimistic about the fact that Congress seems to understand that it still has a tremendous amount of work to be done. That I'm optimistic about. I'm also optimistic about the fact that the way in which this administration is approaching healthcare um, is one that's being approached with, I think, a lot of individuals looking over at the agenda of the secretary. So that make sure that we do not have any concerns about things such as vaccines and so forth are going to cloud, the thinking of people who know just how important those things are. So I offer that in the most political way I can, that I think that those will continue to be good. We have seen a recent comment that the best way to prevent, from the secretary, the best way to prevent the spread of measles is through vaccines. And those are the important things that we really need to continue to do. And we are watching things like the outbreak of vaccines. I, if I'm hopeful about anything, it is that the whole uh, the whole kind of community of healthcare seems to be very much continuing to focus on what needs to be done for a lot of sick people, but also counterbalancing the idea that everyone is sick and all of our efforts have failed. That I don't think is true. And I think a lot of people are beginning to say that is just not correct. So um, we need to just be really good. We need to deliver our message about what's important in kidney care and continue to drive home how important it is because of what it represents to so many people, but also what it represents to the federal government's involvement, but in terms of basically, and also the cardiovascular renal metabolism syndrome seems to be really taking off, and we know that we've got a whole lot to do in that regard.
Thanks, David. Everything Everywhere All at Once is a perfect metaphor for this year. And I think as we move forward, that's probably the best way to try to frame our future discussions is as how do we have all this happen in sort of our own version of the multiverse.
That is exactly right. The multiverse, the kidney patients are still living in the multiverse of many conditions, and our members are living in the multiverse of many things that it takes to deliver care to them. And we are here on our end trying to keep the multiverse all held together. And that's where I think we are, and we're going to keep on working at it.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.